Welcome to the Iowa Influenza webinar for public health and healthcare professionals for the 2019-20 flu season. So just some basic information about the webinar, and then we'll do some introductions here in a little bit. So all participants will be muted during the presentation. You can ask questions, and we'll be checking the QA feature to answer those when it makes sense to answer those questions at the end. The session is being recorded and will be made available for reviewing. So if you know somebody else that wanted to attend but wasn't able to, if they registered, they should get an email, or you can forward it to them when you get it. So just want to cover, just want to make sure people are being able to hear because we got a question. So we just wanted to cover a little bit of influenza activity from this season. Talk a little bit about the surveillance network, which is what makes it possible to get that information. We'll have an update about vaccine recommendations specific to this year. We'll talk about laboratory collection, submission, reporting, and end up with antiviral treatment and prophylaxis. So the presenters, and we'll start out with me, Andy Weigel. I'm the influenza surveillance coordinator at IDPH. Next will be Shelley Jensen from the Immunization Bureau at IDPH. We'll talk about vaccine recommendations. Jeff Benfer from the State Hygienic Laboratory at the University of Iowa. We'll talk about flu labs and results and reporting. And Dr. Caitlin Pedati, our medical director / state epidemiologist from Iowa Department of Public Health, will talk about antiviral recommendations. Okay, so influenza surveillance. I just wanted to look a little bit here at, so what are the subtypes we saw last year? So last year was a little bit unusual in that we saw two peaks of A subtypes. We started out seeing activity around late November, start of December, mostly H1N1 at that point. We that week starting December 16th, we saw 36 H1N1, and then we had another peak of H1N1 March 10th, kind of when we had our overall peak, and then about mid-February, we started seeing a predominance of H1N1, and then we'll talk a little bit about how those different subtypes kind of affect what we're seeing as far as activity and severity and things like that. So before I go into a lot about the other activity measures, I just wanted to talk a little bit about, now we know what subtypes we saw last year, and let's look at a couple years in the past and just talk about how that changes activity and severity and things like that. So you can see the last year when we had such a bad AH3 and 2 year, we had the highest number of hospitalizations, deaths, and long-term care outbreaks, and a tie for the most weeks of outpatient influenza-like illness over the baseline. And then 2015-16, when we had mostly H1N1 year, we had the lowest of all those different measures. And then this last year, when we had kind of a combination of AH3, H1N1, pretty much equal amounts, we had somewhere in between, although it still had a high outpatient influenza-like illness. Yeah, and one thing to point out is I took the numbers of total hospitalizations, but the rankings were still the same when I looked at percentages. And I don't know if I explained this, but the LTCF outbreaks just means long-term care facility. I'll just kind of quickly go over this because I'm going to talk about it again in the next slide. But this is SHL does a respiratory survey, which asks for flu tests from clinical labs and non-flu viral respiratory panels. And so this is where all that information comes from. So this is just kind of showing you, the bars are the number of rapid tests that were done, and the lines are the positive percentage of total A and B. So you can kind of see the peak of testing and positivity was around early March. So we had 33% total positive. And you can also see the A and total positive pretty much track together because A accounted for almost all the positives that we had this season. So this is just kind of showing those last two slides that I showed, the SHL and then the rapid positive, how those two things track together. So the bars are the number of SHL positive tests, and the line is the rapid positivity that I just showed you, but this is looking over the last 5 seasons. So you can see, especially at the start of the flu season, they track really closely together, the peaks do. Oh, geez. Sorry. Oh. And then as the season progresses, the SHL numbers tend to go down first, and then rapid positivity a little bit later for the most part. That's probably due to just the fact that the way the algorithm is now, people tend not to submit as many results as they already know flu is circulating. So then that's kind of the difference into the discrepancy there. And Jeff's going to talk a little bit about a change in the algorithm later on today. Okay, so this is, just wanted to talk a little bit about rapid or the clinical lab tests. I know they're not all rapid antigen versus the tests that we're doing at SHL, and how those vary by time of the season and whether we're seeing flu. So what I did with this, and I apologize if you can't see some of the dates very well, but this is just for this season from September to June, end of June. If sites reported their rapid test positive results when they sent specimens to SHL, and we could get a clear negative or positive on both rapid and SHL results, I put those in this graph, and I'm calling them false negatives. There could be possible other reasons, like maybe it's a different specimen or something like that. But in general, the red and the orange are going to be the false negatives and positives, and the green and the blue are the true negatives and true positives. So like you would expect, we saw false positives more in the start of the season. Before, you can kind of see in green, the start of the season was around mid-November, December. Before then, we saw a higher percentage of all the rapid positives were false positives didn't confirm at SHL. So actually in that first, the week starting October 28th, there was actually 12 out of 12 that were rapid positive were negative at SHL. And then also, like we would expect, the false negative was the highest when we were seeing a lot of flu. So in that week starting March 3rd, 10 out of the rapid negative were also negative at SHL, but the rest were positive. So this low positive predictive value at the start of the season for point of care tests, especially the rapid antigens, is one of the reasons we ask people to submit specimens even during the off season, just to make sure that it is actually flu. And then the other reason has less to do with the predictive value of the specific test, and just more to detecting novel flu, especially during the summer season when there might be animal-related novel flu circulating. So this is just also from that survey that I mentioned earlier. These are the top 4 non-flu respiratory viruses that were detected reported to SHL by that survey, and when they happened throughout the year. This may not be typical of every season, but just last season, the rhino enterovirus was highest percentage of positivity. That's what the lines are, and the bars are the number of tests run. So the rhino entero was highest in October, and then pretty high again in May. The RSV kind of peaked in mid-January. RSV and Corona both had their high positivity rates during flu season. And then parainfluenza 3 kind of was highest at the end of really after flu season had really kind of gone down a lot, at 15%. I wanted to share a little bit about a project that we were funded to do this last year. So IDPH and SHL got money from CDC and CSTE to look at how virus characteristics influenced severity measured by hospitalization status. So with that money, we were able to work with SHL IT folks to get some programming to be able to take the information from the test request form and be able to, calculate and analyze and report that data along with testing data to CDC so they can help us run some stats on that. So basically, this is just our data. What I did here was look at the subtypes that were detected by SHL, and of those that we had hospitalization status on by subtype, how many had reported hospitalization status, and of that subtype, what was the percentage that were hospitalized. So you can kind of see, like we would expect, influenza A was, in this case, all of the hospitalization was due to that was reported. And then none in B. But then what kind of surprised me and Jeff was that the H1N1 actually had a higher hospitalization rate than AH3. Although they're pretty close, they may not be statistically significant. And then, so, just to look into this a little bit, we looked at the age differences, and really that H1N1 had the highest hospitalization rates throughout all the age groups except for 50 to 64, which had higher AH3. But so it wasn't just an age artifact. I also wanted to talk a little bit about school illness. Just because I didn't put that in that first comparison table. One thing I wanted to note was that school illness is any type of illness. It's not just respiratory and definitely not just flu. It tends to be, for that reason, probably it tends to be fairly similar each year. You can see last year was the worst year of these last 4 seasons. And ours this year peaked at around 3.5% in early March. This is flu vaccine reported to IRIS by season. So I just did this as a cumulative so you could kind of see the pattern is pretty similar. Most people get vaccinated by October and November. And then each year or each season, the numbers have gone up a little bit. That could be a combination of reporting to IRIS and also actual increases in vaccination. I think, the number was 1,265,000 doses, which was a 6% increase from last season. Little bit about the surveillance network that is possible for getting all this information. We've pretty much talked about all of those except for maybe outpatient influenza, and that's just kind of a measure of activity from clinics. The big thing to point out here is that flu is not individually reportable, so all of our data comes from voluntary reporting. Reporting outbreaks, I just wanted to reiterate, long-term care facilities basically want you to report as a suspected outbreak anytime you get 2 or more people with flu, suspected flu, and one of them is lab confirmed, when that's been in like 3 to 4 days time period and they all have either the same unit or they have a lot of exposure with each other. And schools reporting 10% illness. I don't have the link updated yet for this year, but since it's still 2017-18, you can report any 10% illness on last year's link on the IDPH page. Just one thing to point out, and I pointed this out to a lot of people that called me about long-term care facilities last year or outbreaks, is that CDC changed their guidance in the middle of last year based on and influenced by the Iowa or Infectious Disease Society influenza clinical practice guidelines. The big change there was there's a little bit more nuance on antiviral prophylaxis recommending, and based on whether they're in the same unit or have overlap with people that were affected by it. and we can help you, or the local public health can help kind of navigate that. The rest of it is pretty much the same: the precautions, the cohorting, the restricting ill personnel, and limiting activities and visitation. Those two guidelines are linked at the bottom here. Oh, and I was going to point out too, the IDSA has a nice table that has suggestions for control measures based on like whether it's the same unit or the whole facility. That I found to be helpful. This is pretty much what we talked about last year, but I know there's some new people on there. Anytime schools or child care centers report outbreaks, which we want you to do, we'll either have the regional public health epi at IDPH or the local public health talk to the school or child care and kind of get some details, figure out, is it a pattern all in the same class? Was there an obvious thing causing it? And then talk to you about things that we might do, either notification or letters, or maybe it's just all spread out and it's something we would expect and it's kind of normal. This is just a reminder of the flu report that we do each week during the peak season. You can get that on the IDPH website, flu website. If anybody doesn't get the email and wants to, you can, my contact information is coming up here, and you can just either call me or email me and ask to be added to that. There's my contact information, and you all get the slides in probably a week or so, so you'll have that information. So now Shelley is going to talk about influenza vaccine recommendations for the season.
Okay, good morning, everyone. So I'm going to talk a little bit about flu vaccination, like Andy said. I want to start with a reminder of how serious the flu can be and how important it is to vaccinate. Influenza is the most frequent cause of death from a vaccine-preventable disease in the United States. Risks for complications, hospitalizations, and deaths are higher among adults 65 years and older, children younger than 5, and people of any age who have medical conditions such as diabetes, asthma, heart, or lung disease. But honestly, everyone is at risk from the flu. Vaccination is recommended for everyone 6 months of age and older. And remember that vaccination not only protects the person being vaccinated, but also protects other people around them, including others who are more vulnerable to serious flu illness, like babies and young children, the elderly, and people with chronic health conditions. Vaccinating pregnant women, for example, helps protect them from the flu illness and hospitalization, and has also been shown to protect baby from flu infection for several months after birth, before the baby is old enough to be vaccinated. The best way to prevent the flu and its associated complications is with annual vaccination. As healthcare professionals, you play a critical role in vaccination efforts. A healthcare provider's strong recommendation for a vaccine is known to be powerful and persuasive in building vaccine confidence and acceptance among patients and parents. And remember to set a good example yourself by being vaccinated. So this slide just highlights this year's vaccine composition. As in past years, there are quadrivalent and trivalent formulations available. The quadrivalent contains an extra B strain. All vaccine formulations are quadrivalent this year, with the exception of the 2 products for the 65 years and older age group. Flu viruses are constantly changing, so the vaccine composition is reviewed each year and updated as needed, based on which influenza viruses are making people sick, the extent to which those viruses are spreading, and how well the previous season's vaccine protected against those viruses. It's important to remember that there is no recommendation for one presentation or product over another. The main thing is to vaccinate with whatever age-appropriate vaccine is available to you when the person comes in to be vaccinated. Do not miss an opportunity to vaccinate and provide protection waiting on a specific vaccine product. As we know, the effectiveness of the vaccine is variable based on the age and health status of the person being vaccinated, as well as the match between the circulating virus strains and the strains included in the vaccine. The flu vaccine is not a perfect vaccine, but even if the vaccine doesn't completely prevent the flu, it can reduce the severity of symptoms, and some protection is better than no protection at all. During recent flu seasons, the flu vaccine has reduced the risk of flu illness in vaccinated people by 30 to 60%. It is our best defense and protection against the flu. So this slide just highlights some benefits of flu vaccination, and this would be national. But for example, during the 2017-18 flu season, influenza vaccination prevented approximately 7 million flu illnesses, 109,000 hospitalizations, and 8,000 flu deaths. So as in previous years, routine annual vaccination for all persons greater than 6 months of age who do not have contraindications is recommended. And as I said, there is no preferential recommendation for one flu product or type of vaccine over another. It is difficult to say the best time to vaccinate because the timing of the onset, peak, and decline of flu activity varies. The ideal time to start vaccinating cannot be predicted each season. It's important to receive vaccine early in the season or before flu begins to circulate to allow time for the antibodies to form and offer protection before exposure. It typically takes about 1 to 2 weeks for those antibodies to form. Flu vaccination should occur ideally by the end of October. It's especially important to vaccinate children who need 2 doses because those doses need to be 4 weeks apart. We want to get them vaccinated as soon as that vaccine is available to assure they are protected by the end of October with both doses. And I'm going to talk a little bit later on about which children meet that requirement for those 2 doses of vaccine. With this in mind, though, remember that it's never too late to vaccinate. Vaccination should continue as long as flu viruses are circulating and unexpired vaccine is available to you. So back to those kids 6 months to 8 years. This is the same recommendation actually as the last few years other than the date. So if a child received at least 2 doses of flu vaccine before July 1 of this year, only 1 dose is needed for the 2019-2020 flu season. Those doses do not need to be in the same flu season or even consecutive flu season. Now, if the child is receiving the flu vaccine for the first time, or if they've not received at least 2 doses before July 1, 2 doses are needed for optimal protection. And as I mentioned, those doses do need to be separated by at least 4 weeks of age. Or 4 weeks, sorry. So for those kids who are 8 who require 2 doses of vaccine, both of those doses should be administered even if the child turns 9 in between receipt of dose 1 and dose 2. The first dose of vaccine really primes the immune system, and that second dose provides that immune protection. So kids that maybe only get 1 dose but really need 2 doses can have reduced or maybe even no protection from a single dose of flu vaccine. So really important to get these kids back in for that second dose. Consider implementing some sort of reminder recall system if you don't already do this. It's also helpful to maybe schedule that second appointment for that second dose when they come in for that first dose to get it on their calendar, and you can send them a reminder to make sure they get back in for that second dose. And we do actually have an algorithm available on our IDPH immunization webpage that kind of outlines this. Might be a nice reference for your clinic and for providers. So people with egg allergies, this is again unchanged from last year. If someone has hives only, you can go ahead and administer any age-appropriate flu vaccine. If there's symptoms other than hives, you can still administer any age-appropriate flu vaccine, but make sure you do that somewhere where there's a healthcare provider who's able to recognize and manage those severe allergic reactions should they happen. There's no specific recommendation for having those people hang around after vaccination for egg allergic persons in general, but ACIP does recommend that all patients should be observed for about 15 minutes following any vaccine administration, just to kind of keep an eye out. And again, we have an algorithm on our website for these people with egg allergies. This slide shows the multiple flu vaccine products available for the flu season. I know it's really small and difficult to read, but I just wanted to highlight how many different vaccine flu products are out there. Again, there's no preferential recommendation as to what brand or product to use. It's really up to provider preference. The important thing is to vaccinate with whatever age-appropriate product you have available when that person comes in to be vaccinated. Don't delay vaccination waiting on a specific product and potentially miss an opportunity to vaccinate. Important to remember that some of these do have different age indications and potentially different dose sizes for ages. So if you stock multiple presentations or different kinds of flu vaccine, be sure to educate your staff administering the vaccine on these different products and indications. Consider labeling the product differences or organizing your refrigerator in some way to reduce the risk of administration errors. So just a few tips and reminders. Flu vaccines should be stored, refrigerated, and protected from light. When using multi-dose vials, you should only withdraw the number of doses indicated in the package insert. Make sure you're always reviewing that package insert. For example, the Fluzone package insert states a maximum of 10 doses can be withdrawn from the multi-dose vial. So for a 5 ml vial of Fluzone, that's about 10 doses. And after the maximum number of doses has been withdrawn, that vial should be discarded or thrown away, even if there is still vaccine in the vial or the expiration date has not been reached. Single-dose vials should not be accessed for more than one dose, even if there's still vaccine in the vial. Pre-filling syringes is discouraged, so it's not recommended to start the clinic day by filling up tons of syringes in anticipation of a busy clinic. This can result in medication errors, storage and handling issues, as well as wasted vaccine. Remember that those general use syringes are designed for immediate administration and not for storage of vaccine. Syringes that you have pre-filled should be discarded at the end of the clinic day if you don't use them. Manufacturer-filled syringes are a good alternative if you have a busy clinic. But again, kind of the same thing. Once you've activated those manufacturer pre-filled syringes, taken the cap off and attached a needle, those should also be discarded at the end of the day if you haven't used them. Vaccines in multi-dose vials that do not require reconstitution may be used through the expiration date unless otherwise indicated by the manufacturer or contaminated in some way. But again, always look at your package insert because, for example, the Flulaval package insert does say that once entered, a multi-dose vial should be discarded after 28 days. So even if you have, a little bit of vaccine left in there, you need to be aware of that 28-day limit. So label that in some way to take note of that. So again, as last year, the flu mist is an available vaccine. So I just wanted to remind everyone that it is a live vaccine. So if you're giving that vaccine with maybe the MMR or varicella, which are also live vaccines, those all need to either be administered on the same day or separated by at least 4 weeks. There are 4 injectable presentations and dosages available for the 6 to 35 months of age group this year, so be aware of those different dosages, especially if you stock multiple different presentations. Changes this year, the Influena age was actually reduced down to age 6 months from age 5. It's 0.25 mLs for the 6 to 35 month of age kiddos, and then 0.5 mLs for those kids 3 and up. The Fluzone, this year you may use either the 0.25 ml dosage or the 0.5 ml dosage. And there's no preference stated by CDC on those. And then the Fluarix and Flulaval, similar to last year, are that 0.5 ml. Remember to always administer the appropriate vaccine and dosage based on the patient's current age at the time of the visit. So if you're using Influena, for example, and a child needing 2 doses comes in at 34 months of age, you would give them that 0.25 ml dosage. And then let's say they don't come back until like 38 months of age for that second dose. You would then administer the 0.5 ml dosage. It's always the current age when the patient comes in. And remember that dose volume is distinct from number of doses needed. So if a child meets criteria for needing 2 doses, it doesn't matter which flu vaccine they got or how much volume they received. They still need those 2 doses 4 weeks apart. So these are just some flu resources kind of as a reference for you guys. The CDC, they have lots of flu information. They also have a special healthcare professional specific section that highlights vaccination. They have recommendations on making a strong recommendation for the flu vaccine and talking to patients and parents about vaccination. And they also have a Fight the Flu toolkit. The MMWR, these are really the official 2019-2020 CDC flu recommendations. Lots of detailed information in there about flu vaccination. The Immunization Action Coalition, they have lots of resources on this site, including standing orders for vaccination and screening checklists. Iowa Department of Public Health, we have lots of information on our website on flu recommendations, and as I mentioned, we have those algorithms for those kids and for people that have allergy to eggs. The Vaccine Information Statement, or the VIS, this, as you know, is produced by CDC and explains both the risk and benefits of vaccine, and it's a federal law to provide this when you give a vaccine. There are separate VISs for the inactivated flu vaccine and the live vaccine, and these were actually updated this year, so the most current date, make sure you're using, is the 8/15/2019 date on those. The immunization program is here to support you in all of your vaccination efforts. We actually have a webpage dedicated to flu information. We also have products available to order for free to support your flu campaigns and outreach activities, brochures and posters. So make sure you check these out when you have a few minutes. And then I'll just leave you with my contact information. I'm in the office Monday through Friday, so if you have flu questions or other immunization type questions such as schedule questions or need some help with catch-up, immunization schedules, immunization law, anything like that, I'm happy to help. So thank you and good luck vaccinating.
Okay, so I'm going to talk about specimen collection, submission, and reporting results, kind of the laboratory end, and then also, what we do with the specimens that you guys send to us. So why to submit? It helps us to monitor when and where influenza is circulating in the community. It also contributes to statewide and national surveillance data. IDPH publishes a weekly report of that data every week. Of course, there are some challenges with the point of care. That has improved greatly since the class 2. In fact, we had a graduate student just did a research project and showed that the tests, the rapid tests, correlate pretty well with our molecular tests now. So we use the CDC assay. It's very sensitive and specific, and then we also provide subtyping results. So with your specimens, that helps, on a national scale, assess is the flu that's circulating matching the current vaccine that was administered, and it also contributes to selecting next year's vaccine, and we have the opportunity to identify novel strains or sequence types, and we can monitor for resistance to the influenza drugs. It also helps us to estimate the burden of disease, so we can see how much of the respiratory illness circulating out there is actually flu versus other pathogens. And also we can look at the level of care, which will help identify if there's a really nasty virulent strain of flu circulating. And then also we can estimate population-based rates. So this is our testing guidance / algorithm. You've probably seen these before. And the big changes last year, we had the bright rainbow colors. Now we have fall colors. Or as one of my coworkers pointed out, it reminded her of pumpkin spice latte. So the most important part, though, other than the colors, is that we simplified the outpatient guidance. So if you're an outpatient facility, we just want you to send up to 2 specimens per week throughout the whole season, regardless of what test method you do. And inpatient recommendations have stayed the same. So regardless of what test or result you have, if they're admitted and you suspect influenza without other apparent cause, please send those specimens to us. Everything else is pretty much the same. So optimal specimen, ideally 3 days post symptom onset, but obviously the reality is you're going to collect the specimen when the patient presents at the clinic. The best specimen to collect would be our combination swab, which is actually a nasal swab, and then a separate throat swab that would be combined into one tube of viral transport media. And it must be in the viral transport media for us to test. And also, if you do another test that goes into a different media, we can't use that because it can cause a chemical reaction with our media or our lysis buffer. So if you need to get collection kits, you can either just call us at the State Hygienic Lab, or you can go to our website and order online. This is our home page, and I circled there, order clinical test kits. Click that. That'll bring you to this screen. You want to select virus isolation and detection kit and the number of kits that you need, and of course your information. To get the test request forms to fill out, you can do that on our website as well. Just click on that clinical test request form button. It'll bring you to this screen, and select viral and bacterial PCR and DFA as the form, and then scroll down and select your facility. The nice thing is you can fill this all out electronically and then print it so it's really legible, or you can just print it and fill it out with pen. So it's important that you signify what specimen type, and then the additional information is really important to us, whether the patient is hospitalized, inpatient, yes or no, and then if you did a rapid test, what that result was. So to get specimens to SHO, you can use, we have a courier system that goes to all the local birthing hospitals. That's primarily was set up for newborn screening, but we can piggyback on that. If you need assistance finding out where the closest place is or setting that up, you can contact Ron Hardy or Becky Teskey at the lab, or if you need help figuring out how you want to get specimens to us, you can certainly contact me as well. Other options, you can send by the commercial carriers or postal service. So main thing about storage is, refrigerate your specimens prior to getting them to us. And if you're going to transport it another method besides the courier, use ice packs. The courier actually has cold sections, so you don't need to worry about that if you're using the courier. and then obviously ship it to us as soon as possible. So we test for all specimens for influenza A and B, and if it's positive for A, we will subtype it for 2009 H1N1 and the H3. And then if it's positive for flu B, we will subtype for Victoria and Yamagata. So we have a web-based reporting system, and if you aren't already signed up, or if you forgot your login or can't get on, you can call that number or send an email and Mike will get you set up, or you can contact me. Additionally, with the web access, you can sign up for email notification to let you know that your samples arrived at the lab. So it'll send an email to you. And also when we have completed the testing and results are available, it'll shoot you an email that you can go in and get your results. It's important if you have staff leave that you contact us so we can remove their access. If you don't have web access, by default you will receive a paper copy in the mail, but then I have to go out back behind the lab with my axe and cut down another tree, and I'm getting kind of old for that stuff. So here's, for web access, you go to our web page, you click on the test results button, and you'll need to click on Open ELIS because that's where the clinical results are. There's a little guide. You can also look at all your options. I'm not going to go into all the details. So we also do a survey. So it's an online survey. The way that works is each week we send you an email with a link that takes you to the survey. You fill it out. Just report what tests you did. And that's not just flu, that's also other respiratory viruses if you're doing a panel. Within that email, we also send you a summary of the previous week so you can kind of see what's going on around you in your area. So the benefit is, not only knowing what's going on around you, IDPH uses it for the weekly report, and it helps to calculate positive predictive values. So if you want to participate, you can just contact me and we will get you signed up. This is what the link looks like. Once you click on it, you fill out your information. This is what the summary of the previous weeks that we send you, kind of looks like. So you see what facilities around you, what testing they did, and how many positives they had for various viruses. And then this is the big summary that will be in each weekly report that IDPH puts out. And there's my contact information. Please feel free to contact me if you have any questions about the laboratory part. And most importantly, thank you for participating and sending us samples.
Okay, good morning. So I think our final topic here today is going to be on antiviral treatment and prophylaxis. So when we think about the antiviral agents that are available for flu, we've got a couple of groups here. We have the adamantanes, which include amantadine and ramantadine. We have the relatively new baloxavir, and then we have our classic neuraminidase inhibitors, which are going to include your oseltamivir or Tamiflu, which is oral, zanamivir or Relenza, which is inhaled, and peramivir or Rapivab, which is going to be an IV medication. So when we think about the adamantanes, they're probably not used very frequently, and there's a couple of reasons why. This is a class that actually targets the M2 ion channel, which is a protein on flu A viruses. So what that means is that this is only going to be active against flu A and not flu B. And then on top of that, unfortunately, we do tend to see high levels of resistance, over 99% to the adamantanes among circulating flu A, both the H3N2 and H1N1 viruses. And so for that reason, this is not recommended for antiviral treatment or chemoprophylaxis of the currently circulating flu A viruses that we typically see. So something that's new on the market recently is baloxavir, also referred to as Xofluza. So this was the first newly approved antiviral medication for flu by the FDA in a really long time. And so this medication is approved for the treatment of acute uncomplicated flu, has to be within 2 days of illness onset, and this is only for people 12 years and older. Now, this medication has a different mechanism of action than our other classes. So this is a cap-dependent endonuclease inhibitor, and it's going to interfere with the viral RNA transcription process, which is going to in turn block the virus's ability to replicate. So this is going to be active against both your flu A and B viruses, but it's important to note that there's not yet any available data in hospitalized patients or for chemoprophylaxis of flu, and it's not recommended in pregnant or breastfeeding women. And then our final big group here is sort of our classic neuraminidase inhibitors, which are typically what we think of as our primary agents for flu A and flu B. And in fact, since these have been around for a while, and because we've had a generic version of this since about December of 2016, this tends to be the group that we've got a lot of good evidence for. And that includes things like the fact that early treatment of hospitalized adult flu patients with oseltamivir has been reported to reduce death. And in hospitalized children, early antiviral treatment with oseltamivir has been reported to shorten the duration of hospitalization. And so for those reasons, often some of the recommendations that you'll hear are going to be more focused on this class of medication. But overall, it's important to know that early antiviral treatment can shorten the duration of fever as well as illness symptoms and may reduce the risk of some complications from flu. Again, it's important to remember that the clinical benefit here is going to be greatest when you're starting treatment as early as possible, ideally within 48 hours of flu illness onset. So as I mentioned, antiviral treatment is going to be recommended as early as possible for any patient with confirmed or suspected flu, especially those who are hospitalized or those who have severe, complicated, or progressive illness, or are at higher risk for complications. And we'll talk about who those people will be in just a moment. And so for this scenario, it's oral oseltamivir that's the recommended antiviral for this group overall. When we think about persons who would be at higher risk, this is going to include our patients under 2 or over 65 years of age. This is going to include people who have chronic diseases, particularly respiratory or cardiovascular illnesses. This is going to include pregnant women up to 2 weeks postpartum. This includes children or those under age 19 who are on long-term aspirin therapy. Our immunosuppressed patients, those who are extremely obese, that's a BMI of over or equal to 40, residents of long-term care, as well as American Indian or Alaskan Natives. And again, for this group, you want to start this as soon as possible after illness onset. So there's no need to wait for a positive lab result in this case. And ideally, we're doing this within 48 hours. However, it's important to note that there might still be benefit, particularly for this group of people, for those with severe or complicated illness, even if we're starting this medication after that 48-hour time frame. And on top of that, antiviral treatment could be considered for any previously healthy symptomatic outpatient who's not going to fall into those high-risk categories for flu complications. And this would be people who are diagnosed with confirmed or suspected flu, even on the basis of clinical judgment, as long as that treatment can be initiated within the 48 hours of illness onset. And so for this group, these are our outpatients who don't necessarily fall into those high-risk categories, and so they're going to have what we would call acute uncomplicated flu, oral oseltamivir, inhaled zanamivir, IV peramivir, or oral baloxavir can be used for treatment. Again, this is our outpatient group with acute uncomplicated flu. And so here you can find, the description of the antiviral treatment dosages. This information will also be available through the CDC's website, as well as through each of these manufacturers' websites, and typically through an institution's formulary. You can see that zanamivir and oseltamivir are going to be 5-day courses. Peramivir is going to be a 1-day treatment, but might be adjusted in somebody who's more severely ill. And baloxavir is a single one-time dose. And for both oseltamivir as well as peramivir, those are going to need to be renally dosed, while baloxavir, there doesn't appear to be a significant difference in the processing of this medication for people with a creatinine clearance of over 50, and there's not good evidence below that. So these medications, of course, can be thought of not just for treatment, but also for prophylaxis, both post-exposure as well as pre-exposure. Now, all of this is to say that this is never a substitute for vaccine or a treatment course if someone were to become ill. So in the case of a post-exposure prophylaxis, you'll want to do a 7 days duration after the last close exposure to somebody with confirmed or suspected flu. You want to give this within 48 hours of the last exposure, and you want to make sure that you're providing your patients information on when and how to seek care if they do become ill. Now, these medications could also be considered for pre-exposure prophylaxis. Now, this might be a consideration if, for example, you've got a patient who's high risk who either can't be vaccinated or was recently, so within 2 weeks, vaccinated, that you're trying to protect after they've had exposure to a flu case. This might also be considered in an institutional setting when there's an ongoing outbreak. And in this situation, you're going to want to give this to all residents for the duration of the exposure. Typically, that's a minimum of 2 weeks, and you'd continue that for up to 1 week after the last known case. Now, again, you've heard a little bit about how some of the recommendations around some of the outbreaks in these institutional settings have evolved over time, and this is an area in which we'd be happy to have conversations with folks if there were questions on how to use this. It's also important to remember that the susceptibility to the flu infection is going to return once these medications are stopped. And so again, what you can see here are the prophylaxis dosages for these medications, which can also be found in a variety of locations, including the CDC's website, which is listed below. And when we're talking about prophylaxis, we're really talking about zanamivir and oseltamivir courses for 7 days, because peramivir and baloxavir are not approved for antiviral prophylaxis. And so that covers our antivirals, but of course, again, they're no substitute for the preventive mechanism of getting a flu shot, which we hope everybody will get done by the end of October. And I think that brings us to the end here, and I believe we might have some time for questions.
So we have a question, are there any confirmed influenza cases yet in Iowa? We are hearing rumors that there have been cases already. Yes, we have had some flu positives. I think we've had 9 since August 1st. Several of those coming in just the last couple weeks. We've had uh, mostly H3 positives, but there's been a couple PDMs too. I've also heard that other states are seeing some early activity. Nothing, rampant yet, but yes, there certainly is some activity.
So So it looks like we also have a question. Why does the new VIS form state interim that has less information than the 2015 version? And I'm actually not sure, but we can look at that and get back to you afterwards. And then it sounds like there's maybe one additional question here. Somebody reporting a delay in flu vaccine delivery and wondering if any others are having issues. I do believe there were some reports that there might be some delays this season. And I think part of that was due in part to the timing of when some of those flu strains were picked. So it just required a little bit extra time to incorporate that into the manufacture and delivery of vaccine. Any other questions for us here? We'll pause, and if you have a question, please go ahead and type it into the chat box there.
So we have a question. Would you say the vaccine was a good match last year? So the reports that I got from the CDC, the flu Bs were pretty good matches. We had really low activity with B last year. The PDM H1N1 was a good match. Which was kind of more at the start of the season. As the season progressed, there was a lot more H3, and then the H3, changed its sequence type, several times like it always does, and there was a certain amount of change that wasn't matching, but overall pretty good. We just had a really long year because we had kind of a long H1N1 season that followed with a long H3 season. Sort of two separate seasons, but overlapping.
Are you hearing any shortages of Tamiflu? Where it might make this?
So we have another question here. Are you hearing of any shortages of Tamiflu where it might make us consider only prescribing it to high-risk individuals? No, we've not yet been made aware of any shortages of Tamiflu, but that's certainly something that we'll keep an eye out for and communicate if it does come up. And again, if you'd like to ask a question, please go ahead and type it into the chat box, and we'll give it just another minute here. So we have a question here. Is there anything that can be done to encourage hospitals, clinics, and public health receiving their flu vaccines before commercial pharmacies, especially in a vaccine shortage? In terms of distribution of the vaccines themselves, I think that really occurs between an agency or an institution and the distributor of the vaccine. So I'm not sure that there's a lot of control that we necessarily have here from the health department. But certainly if anybody is, having difficulties or, needing help, please feel free to reach out to us at the health department and we can at least see if there's anything we can do to support you. Again, we'll give it just another minute here for any other questions. So seeing no additional questions here, we'll probably go ahead and wrap up today's webinar. But certainly this is not your last opportunity to reach out. If there's any additional questions that come up at any point, please always feel free to reach out to us at the health department. And thank you all so much for your attention today and for your help with this flu season.